Vertebral arteries, the main blood supply of the spinal cord. Okay. So next we are discussing about descending tracts. We have just finished our ascending tracts. Now we are going to discuss about the descending tract. Descending tracts, what I said, these are motor tracts. Okay, motor. Okay. So descending tracts, we are having pyramidal and extrapyramidal. So pyramidal tracts are lateral corticospinal tract and lateral corticospinal tract. There is anterior corticospinal tract. Name itself is cortex to spine. Okay, name itself is going to explain you the descending tract or ascending tract. Just remember corticospinal, from cortex to the spinal cord. Okay. So these are your descending tract. It is your nothing but descending tract. So it starts from the cortex, motor cortex 4 and 5. Sorry, 4 and 6. And fan like projections. It starts like this. Fan like projection. Okay. So from here goes into the thalamus and it descends to the midbrain, pons, midbrain, pons, descends to the medulla oblongata. Okay, descends to medulla oblongata. Descends to medulla oblongata. Okay, from medulla oblongata, it decussate. It crosses 80% of the fibers are crossed and 20% fibers are uncrossed. This 80% of crossed fibers enters into the lateral corticospinal tract. This is your lateral corticospinal tract. Okay, and descends to the ventral horn of the spinal cord and it comes out as lower motor neuron. Okay, this is your lateral corticospinal tract, and the 20% of fibers which are present, it descends to the ventral corticospinal tract. Okay, it goes into the ventral horn. From there comes out as lower motor neuron. Okay, so anterior corticospinal tract. Okay, what is its functional significance? Functional significance is nothing but it takes fine voluntary skilled movements. Fine voluntary skilled movements, and also it facilitates flexors and inhibits extensors, and it inhibits extensors. Okay, it inhibits your extensors. Also actions from basal ganglia and cerebellum. Actions from the basal ganglia or cerebellum are also controlled by these tracts with these tracts. Superficial reflexes and also functional. Superficial reflexes and muscle tone. Okay, this is your pyramidal tracts. So next we are going to discuss about the clinical anatomy of these tracts. Okay, amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis. It is degenerative disease. Degenerative disease. What it degenerates? Cells of the ventral horn on the spinal cord. Okay. Cells in the ventral horn. What are its clinical features? So when the cells of the ventral horn are degenerated, what it happens? Muscle wasting will be there. Muscle wasting will be there. Call it as atrophy and weakness. So these are its clinical features in amyotrophic lateral sclerosis. Next, this is we are going to discuss about subacute combined degeneration. So the posterior and lateral funiculi are degenerated bilaterally. Why? Why it's going to degenerate? Because there is an intrinsic factor. Intrinsic factor deficiency. Why? Intrinsic factor deficiency, which helps in absorption of absorption of vitamin B12. What? Okay. So intrinsic factor which helps in absorption of vitamin B12. Clinical features. Upper motor neuron paralysis. Okay. So here we are going to discuss about upper motor neuron and lower motor neuron. So upper motor neuron features, lower motor neuron. So in upper motor neuron, if there is happened anything in the upper motor neuron, you will see spasticity, hyperreflexia, no muscle wasting and contralateral. As I had discussed earlier, so this is your upper motor neuron. Okay, from cortex to the spinal cord. From the spinal cord, it goes outside. This is your lower motor neuron. So here you can see 80% of the fibers are crossed. So crossed fibers. So upper, if there is anything happen in the upper motor neuron, so the deficiency because of this upper motor neuron, it will be contralateral. So if there is anything happen in the lower motor neuron, it is ipsilateral. So here you can see. So the same way, so upper motor neuron paralysis will be contralateral. So there will be no muscle wasting. Hyperreflexia will be there. Hyperreflexia, the muscle is working a lot. So there will be no muscle wasting. Spasticity will be there. The opposite side, exactly opposite to the upper motor neuron. Here you will be seeing flaccidity, hyporeflexia, hyporeflexia. Muscle wasting will be there. So muscle is not working here. So muscle wasting will be there. And I had discussed right now it is ipsilateral. Lower motor neuron is ipsilateral. So next we are going to discuss your most important topic, Brown-Sequard syndrome. Okay, Brown-Sequard syndrome. Hemisection of the spinal cord. When you cut the half of the spinal cord, you will these are the uh, this is known as Brown-Sequard syndrome. So I had discussed earlier, you can go through the video again regarding the tracts and all. When you cut half of the spinal cord, those tracts will be not seen. For example, I will show you here. For example, this is the spinal cord. So okay, this is the ventral horn. The tracts which are present here. Okay, the dorsal column is gone, lateral corticospinal tract is gone, ventral corticospinal tract is gone, lateral spinothalamic tract is gone, ventral spinothalamic tract is gone. So here we are going to apply the anatomy here. Okay, so pyramidal tracts, I told you, lateral corticospinal, anterior corticospinal tract. So this is your upper motor neuron type of. Here you are going to see upper motor neuron. Upper motor neuron paralysis we are going to see because of the pyramidal tracts. It is ipsilateral or contralateral. It is ipsilateral because pyramidal tracts are going up and it only crosses coming down only crosses at the middle of oblongata. Okay. Next, posterior white column is gone. Here you will be seeing ipsilateral loss of proprioceptive sensations. Proprioceptive sensations are gone. It is also ipsilateral because I have fasciculus gracilis, fasciculus cuneatus is going to take this. Okay. And contralateral loss of pain, touch, temperature, exteroceptive sensations. Huh? Temperature, pressure, these are your exteroceptive sensations. This is because of sensations are carried by which tract? Exteroceptive sensations are carried by anterior and anterior and lateral spinothalamic tracts. This is the only one which is contralateral in Brown-Sequard syndrome. So at the level of lesion, these are the clinical features which we observe at below the level of the lesion. At the level of lesion, I had discussed you contralateral loss of pain, temperature, and sensations. Ipsilateral root segment sense. Okay. At the level of the lesion, you will see anesthesia over the skin, sensations over the skin or the are gone, and ipsilateral locomotor neuron paralysis. Okay, locomotor damage to the ventral nerve roots. Above the level of lesion, you will see hyperesthesia. Hyperesthesia. This opposite word of anesthesia. Okay, hyperesthesia due to irritation of the dorsal nerve roots. The next uh, clinical anatomy disease we are going to discuss here, syringomyelia. Okay, so in the spinal cord, at the spinal canal, cavities are formed, and it increase formation of cavities and around the central canal in the low, mostly it is in the lower cervical region. Okay, so what happens when the central canal go around the central canal, this gray matter got degenerates, and what you will see, bilateral loss of pain and temperature, the tracks which they are crossing inside the spinal cord, those are affected. So because of that, you will be seeing bilateral loss of pain and temperature. Okay, because of lateral spinothalamic tract. Lateral and anterior spinothalamic tract are mostly affected. Okay, so mostly it's in lower cervical region, so it affects the upper limb. Okay, so thank you guys. Thank you.